Dr. Howard I. Mark. I'm an oral surgeon, and I was involved with getting COHI started back in 1999 2000. Was a deep interest of mine for many years, was taking care of people who could not afford oral health care. Volunteered at several hospitals doing pro bono care for people with problems with oral, with infections and so on related to the dentition. And myself and another dentist, John Shaw, who was practicing at that time at Hartford Hospital, who was no longer in this area, came together, and we were of one mind that we needed to do something more than just volunteer. We came up with the name of the Connecticut Oral Health Initiative, and as luck would have it, it was at the time when the Connecticut Health Foundation was spinning off from Connecticut at Hartford Hospital. At that time, there was some legal involvements, and they had to spin it off into a foundation. It became, and it still is, I believe, the richest foundation in the state, and has done a tremendous amount of work in the health area. I served on the board of that as it got started, representing dentistry for about 7 years. And it grew into something very, very beneficial for many, many people and institutions across the state, because it helped fund it and get it off the ground, which we were very grateful for. It helped us bring in other groups into the organization, the Connecticut Dental Association, the Connecticut Medical Association, nursing associations, and even some of the hospital hierarchies became part of it as well. At that time, one of the big problems was that dentists had not had any raise in any of the Medicaid programs that were extant at that time for a number of years. So we fought for that. As one of the first things we wanted to do was to get dentists involved. And if they're not being paid somewhat reasonably, they certainly wouldn't attend that function. That was one of the major areas. Other major areas were getting institutions that were involved with health interested in providing oral health. And some of the institutions we worked with actually put dental residencies into place for at least a few years. But again, reimbursements over time, they had to drop them. They couldn't afford, with the payments on Medicaid programs, they couldn't afford to stay alive. But we tried. So we also brought in other organizations from across the state, the Southwest AHEC, among one which was quite involved with us, the Hispanic Health Foundation. And as a matter of fact, we moved into the Hispanic Health Council's offices on Main Street in Hartford as one of our first offices, which was wonderful because we were then involved with the Hispanic communities and the health programs that they were affording for this. And we got some of those people to come on the board and help us develop oral health relationships within that community. That was quite good for us. At least gave us a foothold into an area that we had not been in before. And the dental organizations also joined with us, which made it worthwhile to do. But again, we had to keep getting funding. Dr. Shaw worked as a part-time executive director for a period of time with no pay. I, of course, never got any pay. We weren't looking for that. And we brought on board, as I've said, some of these other organizations and developed a board. We had a pro bono legal opinion as to how to get the Connecticut Oral Health Foundation Initiative a 501c3, which was very nice through Robinson and Cole. That helped. And then we also worked with a pro bono, the Greater Hartford Legal Association, which helped us as well. So it really became something that continued on for a period of time, fighting the usual problems with the legislature, funding programs that we needed, that oral health people needed, and that the population needed. We worked very closely with the Connecticut Health Department. In fact, some of the people in that area worked with us on our boards as well. So we really developed a lot of cohesion. The big problem was that oral health was not cheap. The ability to serve the communities was not cheap because of the need for specific equipment, plus people to man these areas, dental residents, even a community dentist or two. So it really took a lot of effort to bring these people into our purview. One of the other areas that helped us were the teachers in the school system in Hartford particularly seemed to be very interested in oral health, and some dentists over time performed dental care within the schools in Hartford, which then developed the community health system on Albany Avenue in Hartford, which became part of us as well. So over time, we tried. First of all, oral health is important to health. If you don't have good oral health, and remember, the mouth is the entree to the body. Many things pass through it, obviously. It reflects disease in other areas. Diabetes, for example, is something that reflects in the mouth with periodontal and gum disease, so-called. What you eat, sugars and so forth, besides reflecting into possible diabetic conditions, also would then cause problems with acidic decay on the teeth. So that was very important that we begin to look at these areas and see if we could get people interested, first of all. And you have to realize that, and I quote this all the time, the Surgeon General of the United States issued the very first brochure or report rather on oral health in America in the year 2000. Before that, there were over 28 reports on tobacco and its effects. So it looked like oral health was in the wastebasket, if you will. It was just not being taken care of or even thought of. His report was really an eye-opener with whatever statistic base he had at the time, showing how dental decay was rampant, ubiquitous is the word, I guess, throughout the country. For example, it had such an effect that the estimation was that over 1 million hours were lost by children in schools because of dental decay and pain and the inability to function from an educational point of view as well as a health point of view. All those things just was very interesting that they all came together at that same time. And by the way, the second report, which has just come out, now this is 2021 basically, and that other first report was back in 2000. I mean, we're talking 2 decades before a second report on the status of oral health in America was issued by the Surgeon General's office. That's a travesty within itself, that something so vital and really so easily accessible for study, for research, with the impact possibilities that could be given to it, that would involve areas of drug abuse, all those things that have impact upon patients taking care of themselves, mental health situations, the cost of the care that is really much too much for many sectors of our populations. It's really a travesty when you think about it that has not been looked into for all these years. The other is that the cost of insurance, and back in the days when I started, the dental health coverage was limited to about $1,500 to $2,000, which maybe in the early days was okay, but it was like a lost leader for the medical care, so that they offered the dental care sort of as a add-on, no charge to the companies getting the medical care, just to give them an incentive to take it. Now, that has not changed in any real way for all these years. So when you consider that the cost of dental care has skyrocketed, and a lot of it is due to technological advances that cost the dentists and dental professions a good deal of money to install, but are necessary for understanding better the health of people, it has not helped people get access because they can't afford it. And if they have insurance, it may cover, maybe a cleaning, one or two a year, but that doesn't cut into it if they need to have dental repair or crowns or bridges or implants, all these things. So we really need to look into all of those aspects of dental care in order to make sure that the population gets what it deserves. Dentistry is, again, as I've said before, the entree to the body, and reflects not only in the teeth, but the tongue, soft tissues, the pharynx, the palate, all these areas that reflect problems with things like lymphomas and leukemia and so on, really have an impact. And if they aren't looked at and get out of hand, they are really devastating for the patients. Cancer is certainly one of the main ones that we can consider. When you think about the use of tobacco, we know how much tobacco causes cancers in the mouth from not only smoking but chewing tobacco. Pipe smoke, cigar, not as bad, but nevertheless, we're part of the mix. And if you have dental care, at least somebody's looking in the mouth and maybe can pick up something early when it wouldn't be as devastating as if neglected and allowed to fester. The support for oral health is nowhere what it should be. Most dental organizations like ours, and there are a number across the country, of course, they function with bare bones. I would venture to say that even the COHI, which has been in existence since, as we've said, since 1999 and 2000, the amount of money that is needed. I mean, you have a bare bones staff. We have an executive director, perhaps a couple of part-time people, and the budgets that we have are less than $300,000. You go to some of these medical places, you're talking in the millions. So that there's nothing that can keep this going except for the ardor of the people involved. If the importance that they reflect allows them at their own risk, in a sense, to get less pay for doing a big job, but they do it for the love of it, and that, I think, is really what is necessary. And so organizations should look at us and look at the worth of what we do, look at the impact that we can make by dealing with the legislature, helping organizations put together dental programs, get them off the ground at least, even if it's strictly a look-see and an exam, and then maybe a referral to a dentist, but at least it's a beginning, and it makes people understand that there is a value to brushing your teeth, keeping your mouth clean, and making sure that you have a visit with even a nurse in the school systems, at least to identify a problem and get it before it becomes a major difficulty. Parity across the board is an extremely difficult problem. And let me diverge for a little bit. No matter how you want to do it for the lower populations, the more needy populations, if you look at the people who can afford it, the percentage is appalling. If they can afford it, even if they can pay for it, it's under 70%. And that alone is a bad figure. When you look at what the lower populations affect, you might be looking at something that is well below 50%. And the minute you start seeing that, you know that the problems will exist. Remember that a patient who develops a problem and hasn't had care and goes to the emergency room at a hospital is a very expensive visit, for one, but the care that they get is very limited. Unless there's a dental program at that hospital, and there are very few now in the state because of the cost of these programs, what they do is just give a prescription and maybe a referral to a dentist, and who knows if it even gets taken care of, because if they put them on antibiotics and give them pain medications so they feel better, they neglect it after, as that's going along and they feel comfortable. You need to have parity, and the only way to get parity is by making sure that insurance coverages, that the dental industry itself makes costs a little bit more palatable. The cost of dental care is skyrocketing, and I'm not sure that is all legitimate in the sense, and I hate to say that, but remember that the cost of having a staff, hygienists, and all the ancillary people is expensive, and so dentistry has to charge for those. But the population they serve may not be able to afford it.